Okay, great. Let's get started with tonight's Zoomposium. Very, very exciting. But first, I'd like to just bring attention to today. Is June 8th, 2022 is actually World Brain Tumor Day. Please take a moment to try to educate those around you and expose them to something that obviously neurosurgeons and physicians are exposed to all the time, but we need to definitely raise up this diagnosis in order to raise awareness, educate, and try to find better treatments available for those around us and figure out ways that we could support those of us who are undergoing these devastating diseases even better. So welcome to the Miami Global Brain Tumor Symposium. My name is Michael Ivan. I'm one of the brain tumor skull-based specialists here at the University of Miami, and I'm joined by my co-directors today, Dr. Komatar, who's our program director and our director of surgical neuro-oncology, Dr. Morkos, chairman of neurosurgery and director of our cerebrovascular and skull-based program, and Dr. Benjamin, who's director of our skull-based lab, as well as an assistant professor here at the University of Miami. Again, I cannot do these symposiums without all the gracious and help from all of the University of Miami, Sylvester Comprehensive Cancer Center, and the neurosurgical department. There's so much work that goes on behind the scenes, and we can never thank these guys enough. Again, if you want to find more about brain tumors or about neurosurgery, you could always visit us online or on social media. Most importantly is that all of these videos are stored on our YouTube channel. Just search for University of Miami Neurosurgery, go down to either the playlist or to videos, and you could see all of the brain tumor symposiums kind of lumped up together, and you could pick your favorite ones. Many people, thousands of people have done so far thus far. Again, some housekeeping. We try to make this as interactive as possible, so please use the Q&A button. That's probably the most important thing. So this week, we have panelists, all who are on the cusp of starting their own careers in brain tumors, and we're very proud of each and every one of them. Dr. Ashish Shah, who's a graduate of University of Miami and now finishing up his fellowship at the NIH and the surgical neurology branch, again, focused on brain tumors immunotherapy. He's going to be joining us here at the U as a director of clinical trials and translational research for brain tumors, as well as a brain tumor surgeon. Dr. Patel came to us from Rutgers. He's finishing up his surgical neuro-oncology fellowship, just a few days left. He's done a phenomenal job and will be joining Hackensack Meridian School of Medicine in New Jersey as an assistant professor focused on brain tumors. And Dr. Higgins, who joins us from Columbia, also just a few days left, finishing up his surgical neuro-oncology fellowship, done also a phenomenal job, and he'll be joining the University of North Carolina as one of their brain tumor specialists with a brain tumor lab focused on gliomas. So thank you all. This week, I have the honor of introducing one of my junior residents, and there's nothing more exciting and more proud for you to do than to introduce somebody on this scale who you've taken some kind of part in their education, although it's small part that it be. Stephen, you can see us here. Actually, this is one of the last days of my residency in the bottom left, joined to us by one of our biggest mentors, Dr. McDermott, and our co-residents there, Dr. Rukowski and Dr. Brashears. Stephen is joining us today from Northwestern, where he's an assistant professor and focusing on skull-based and brain tumor surgery at their Department of Neurological Surgery. He graduated cum laude at summa cum laude from University of Pittsburgh, went to University of Oregon, got his MD, PhD, and then joined the residency program at UCSF, where he flourished with all of the brain tumor and skull-based support that you have there. He did phenomenal work while he was there with multiple groups, specifically Dr. Raleigh had an NIH-funded research year, had multiple papers, which I'm sure you'll hear about today, published in neurosurgery and also in Nature Genetics and Nature Communications on his passion, which is meningiomas. And so we're really excited for him to kind of share all of what he's done while he was in residency, and then also during his fellowship at Ohio State with Dr. Prevodello, and now what he's going to move forward with his practice at Northwestern. So Dr. McGill, thank you so much for taking the time to talk to us about meningiomas.
Thank you for that very kind introduction, Mike, and for inviting me here. Let me just share. All right, you can see my screen now?
Yeah, that looks great.
Yeah, perfect. So thank you for the invitation. This is a real honor. This is a big stage where, I've seen many of my mentors and people present, and I'm excited to share with you some of the work and the way that I'm thinking about meningiomas these days. And in specifically trying to take some of the data I'll share with you from those papers Mike mentioned, and then incorporate that into some clinical case examples that I think are relevant and kind of give a taste of the future of meningioma care. As Mike mentioned, this is work, much of the science I'll talk about is work I did at UCSF, and through an ongoing collaboration with David Raleigh at UCSF, we're continuing to do research and apply for grants and things together. So one of the things, why do we need new scientific insights into meningioma? And I think if you look at this nasty, enormous meningioma here, that was a WHO grade 1 meningioma, and clearly it's not behaving like a grade 1 meningioma. And so I think understanding the biology of these tumors can really give insight into refining our care of the patients and also guiding how we manage them, and then ultimately identifying new treatments. So I have no financial conflicts of interest. I will talk a little bit about off-label use of drugs. This is kind of how I laid out the talk here. So a brief background on meningioma basics, and then try to highlight some of the controversies. We'll talk a little bit about translation of molecular advances, particularly focusing on genetic and copy number variations, DNA methylation profiling, and then also on a new gene expression panel I'm excited about that can predict some radiation responses. In the closing, I'll give a couple examples of how I'm also using dotatate PET to guide surgery, and I think it's exciting to see, where we can push things surgically, and then close with some information on trials. So the basics: meningioma is the most common primary CNS tumor, 32,000 diagnosed a year every year in the US. They're extraaxial. They compress the brain or adjacent cranial nerves, so can present if they're supratentorially with headaches, seizures, cognitive changes, and along the skull base, often with focal neurological deficits. Increasingly, these are discovered incidentally. This is a disease predominantly of women, 2 to 1, and it's also more common in Blacks, and in particular, the malignant meningiomas are much more common in Blacks than white. The meningiomas are graded grade 1, 2, and 3 based off the World Health Organization grading. Grade 1 is anywhere from 70 to 80%, grade 2, 20 to 30%, grade 3s are quite rare. Outcomes are very good for grade 1. 75 to 90% of folks will make it 10 years, 23 to 75 for WHO grade 2, they're more likely to recur, and almost no grade 3s will go 10 years without progression. And how do we manage them? You can it's observations. So we just watch it. If they're slow growing or not asymptomatic, take them out surgically, or we can radiate. And that's really the end of meningioma treatment right there. There's no approved medical therapies. And so when we have tumors like that big one I showed at the beginning, or tumors that keep coming back, there's really an unmet need for new medical treatments for these. When we look at meningioma outcomes, I alluded to that already. These are Kaplan-Meier curves for 10 years, recurrence-free survival. You can see that for benign meningiomas, it's very good, but actually 25% will recur at 10 years, roughly, depending on who you look at. But there is a real a group of tumors that we don't understand why they come back. Atypicals, about 40% will recur at 5 years, and anaplastic, about half will recur around 2 years. That correlates with overall survival as well. I have mentioned one of the reasons I'm interested in meningiomas, it's a surgical disease. Going back to 1957, we're all familiar with the Simpson grade, 1 to 5, with what Simpson found now, 60 years ago, was basically the more complete removal of the tumor we can get, the better the patients do. And when we look in our series that I'll talk about sometimes, throughout the talk from the Nature Genetics paper of 565 meningiomas, we see that still holds up in the modern era, where gross total resection has decreased freedom from recurrence, or longer freedom from recurrence compared to subtotal resection. And that also is a significant difference in overall survival if you can remove all of the tumor. Multiple other authors have shown this. This is a very similar thing, just showing multiple series over the years. Gross total resection, if you look at 5-year recurrence rates, 7 to 23, 10 year up to 30, 15 years, and there's not very many studies looking beyond 10 years, but that rate actually goes up, and that's one of the things we'll talk a bit about today. Much worse, many more patients with subtotal resection will recur. The other treatment we have, radiosurgery or radiation therapy. The biggest study was by Santa Croce. He looked at 5,300 grade 1 meningiomas from 15 centers, and the 10-year progression-free survival was over 90%. This is a standard radiosurgery paradigms of either a hypofractionated, or most of those were 15 gray and 1 fraction. And when we looked at in the UCSF cohort, we saw that very similarly. For grade 1 or imaging-defined meningiomas, 90%, 5 years, no progression. So that's why I think meningiomas kind of get kicked to the side from a disease standpoint, because as everyone in this audience knows, it's not killing patients right off the bat like glioblastoma. And even in the seminal review by Rogers, the first thing they say is the majority of meningiomas are benign. But I would argue that the morbidity that these cause to many patients actually is quite disrupting. And as we just saw, that can come back, require multiple treatments, and you can have side effects, complications, things like that from the surgery. And grade 2s and 3s will definitely impact patients' life. So when we think about what are kind of the controversies, that's the basics of meningioma. The controversies, I think, are how long do we follow patients? This is a patient of mine, convexity meningioma, we'll talk about throughout the talk. Grade 1 tumor, Simpson grade 1 resection. You can see I drilled the bone, dura is gone. How long should I follow this young lady? Who should receive radiation? Adjuvant radiotherapy. These are 2 grade 2 meningiomas took out recently. And we'll talk a little bit about, the equipoise that is out there regarding radiation, and also the exciting new things that may help us guide who should receive radiation. And then what do we do when the tumors recur? And this is a patient we'll talk a little bit about who had multiple surgeries and now has a recurrence, and it's a bad tumor. So we'll talk a bit about that. So let's dive into some of the cases. This is that lady I was just showing you, 39-year-old woman, presents with 6 months of headaches. We could have watched it or treated it. She was young. There was some bone invasion. She wanted to move forward with surgery. So I think that's reasonable given the brain compression. And so this is the resection I just showed you. We got a nice resection for her. Pathology, grade 1 meningioma, Ki67, 3%, Simpson grade 1 resection. What should we do? One of the things that I've started thinking about a little differently is starting to think about meningiomas a bit as a cancer. So I often send a dural margin. And one of the dural margins I sent looked like this, which is just normal dura, and that's clean. So I knew, even though that rim of dura that I cut out, it's clean, no problem. But if you look at the intraoperative picture, the tumor had been compressing this vein here, and I took it all the way back close to the sagittal sinus. And as I cut this chunk of scarry tissue, not clear whether it was tumor or just thickened arachnoid and dura, where this vein was going into a lake here, I cut back as much as I could of this. I sent that separately as a margin along the sinus, and there's actually meningioma in that thickened stuff. It's not a lot, so maybe I got it all with that scissor snips I took right before I took the picture, or right after I took the picture, or maybe there's cells trailing off that are residual. So gross total on MRI, but maybe a tiny residual, that you can't see. Molecular pathology, we do a lot of that here at Northwestern. So we checked for TERT promoter, it's negative. Then we did copy number variants. And one of the things that we noticed is there were several gains of chromosomes. You can see here, loss of 16, 18, and haploinsufficiency of NF2. Importantly, in the new WHO grading system, homozygous loss of CDKN2A or B, which is located on chromosome 9, puts you automatically a grade 3, and she was normal. So we send all of our meningiomas for methylation profiling, which we can do in-house here. And the methylation profiling came back meningioma. So that's where we're at with what we can say from methylation right now. So how does this change management for this patient? What do we do? Grade 1 meningioma, probably just follow it. And what can we learn from the DNA methylation profiling? 2 questions I want to kind of highlight out of this. So we were interested in, what is her recurrence risk? Grade 1 meningioma, we looked at 823 patients at UCSF in a paper that's coming out shortly, and looked at recurrence. And what we found is, almost nobody recurred within a year. So waiting a year to get a scan, probably okay. 5 years, 10%, 9% would recur. At 10 years, that was 83%. At 15 years, 77% of the patients had recurred. That's 36 of 823 that we had that long a follow-up on. We saw a significant difference whether or not you got a Simpson grade 1 or 2 resection. And we saw a significant difference more likely to recur if your MIB labeling index was greater than 8. So if it was less than 8, you had much longer recurrence-free survival. So that's where Our Lady sits, looks like fairly benign. But the most important thing that we found is we used a decision tree analysis to see what were the most important factors in predicting recurrence. And the most important factor, which is somewhat intuitive, is the follow-up duration, followed by MIB1, size of tumor, age at surgery, and sex. So this is a younger patient. The sex is male, that puts you at risk, but really we need to keep following her. And I think that's one of the important things that came away from this study. So our group had the caveat, the median follow-up was only 2.7 years in all the patients, but the median follow-up of recurrent patients was 10 years. So we suggested a minimum of screening for 8 years if your MIB1 is less than 8. And if it's greater than 8, you should probably screen at least 12 years for recurrence. But this is really an area that, this is retrospective. This is kind of taking what we can. And I think the take-home message is really that we do need to follow these patients for a significant amount of time. We can't just say you're cured and let them go. Copy number changes. This was her copy number profile. She had several of these. What does that tell us? Well, one of the things that we know is the meningiomas have genomic instability. And the most common copy number variant, 22q loss, then 14q, 1p, and so on. But there's a whole smattering of chromosomal losses that can occur, or gains. In the meningiomas that have the worst clinical outcomes, which I'll talk a little bit more about shortly, this hypermitotic group, there are a lot more copy number variants. So when I see a case like hers with multiple copy number variants, I'm starting to think maybe she's actually one of these people who is a grade 1, but might be at greater risk for coming back. When you we did a study looking at intratumor heterogeneity, and if you sample the copy and do copy number profiling at different locations within a tumor, this is a grade 1 meningioma, you often see this, a stable karyotype throughout the tumor. This one just had 22q loss throughout. If you compare that to an example of somebody who has a grade 3 recurrent meningioma, this massive thing, and we profile different regions of the tumor, the whole tumor has all of these variants here, 1p, 4p, 14q. But then each different site within the tumor had additional unique gains or losses of chromosomes. Some were similar, but showing that the genomic instability that we see as tumors get higher grade actually has a spatial heterogeneity to them. What does the methylation tell us? When we get a score like this, it says, well, it's a methylation, that's a meningioma. This analysis and data comes from the really important paper from the Heidelberg group by Capra et al. In Nature, where that was classifying meningioma brain tumors using methylation. So if you put any methylation profile into their algorithm and separate based on in the t-SNE space, it'll cluster with one tumor or another. So if we look at our sample, she clusters with all the meningiomas, but that's about all it can tell us because that's where this data came from. So to try to answer and dive a little bit deeper into what can we learn from the copy number variants, aside from more copy number variants is bad, I'd started a study where we profiled 200 meningiomas from UCSF and then an independent validation cohort of 365 meningiomas that were resected consecutively at the University of Hong Kong. And we did DNA methylation profiling and saw 3 groups that predicted freedom from recurrence. And, the first group is what we call the Merlin intact group. These tumors have the best clinical outcome. You can see here, very similar to the historical curves that we saw. They're characterized by neutral chromosome 22. And we did some research looking at what mechanistic features are going on in these meningiomas. And we studied Merlin, which is the gene product of NF2. So these patients have Merlin, and we discovered a novel role for that protein in promoting apoptosis. So even though they evolve into a meningioma, they still have NF2 present, which allows these tumors, when they become unstable, these tumor cells undergo apoptosis. Whereas when you lose Merlin, you have decreased apoptosis and increased tumor growth. We created a couple cell lines to look at this. And when you look at which tumors fit in this group from our profile methylation group, most of them are grade 1s, as you would expect. but there was a handful of grade 2, 17% that had a better clinical outcome, which you see here on the local freedom from recurrence and overall survival. Very few grade 3s. The next group that we identified is one we called immune enriched. This is, I think, similar to the group that Nassiri et al. Published it from Galeray-Zadeh's group. These are meningiomas that have an intermediate outcome. One of the things we found is there was some gains on chromosome 6, and specifically at the HLA locus. And these tumors often have loss of NF2, chromosome 22. They have increased immune infiltration, and they also have infiltration of meningeal lymphatics. So we did mechanistic studies, and you can actually see lymphatic vessels or glymphatic vessels from the meninges infiltrating into the tumor, which may explain some of their behavior. We characterized several cell lines that fit in this group. And the distribution of these patients by WHO grade is very similar. They tend to have a better outcome. But there's a number of grade 2s and a number of grade 1s that are different from these Merlin intact tumors that may then have a worse clinical outcome. The most aggressive group that we found, and these are the ones that we really need help with, are ones we term hypermitotic. These patients are characterized by a loss of chromosome 1p, a gain of chromosome 1q, and I'll talk a little bit about some of the mechanisms we discovered that why this is important. They often have 9p loss, which contains the CDKN2AB locus that promotes cell cycle activation, as well as 14q, and almost all have 22 loss. For these interestingly though, if you look at the WHO grade here, the mechanism in these tumors is they have overactivation of the cell cycle. A number of grade 1 tumors actually fit into this group. So maybe like our patient who is a grade 1 meningioma, but she's got some other copy number variants and things. And, maybe is she a hypermitotic tumor and genetically much more aggressive? So when we look, I'll get back to her in a second, but when we looked at this methylation profiling in the context of known meningioma risk factors, so extent of resection, WHO grade, adjuvant radiotherapy, whether or not you've had it, whether it's a primary tumor or a recurrent tumor. DNA methylation, these subsets all were on multivariate analysis, were significant predictors of local freedom from recurrence, suggesting that what we're finding in the DNA methylation is additional information in regards to in addition to the WHO grade and other clinical variables that we know are important for meningioma. This is the copy number variants of these tumors that define that. If you look at the frequency of copy number changes, so Merlin intact over here, chromosome 22, most of these are neutral. Immune enriched, you see a loss of chromosome 22, same there. And then the hypermitotic meningiomas are really defined, and if you look, almost none of them have this 1q gain. Some of the other groups had 1p loss, but really this 1q gain we found to be very unique. So we wanted to know what could be going on there. And when we looked at the genes on chromosome 1q, we identified this gene USF1. USF1 is a transcription factor that is amplified in a number of these cases. And you can see compared to the other groups, we see many more meningiomas with USF1 amplification. USF1 is a transcription factor, and if you look at ChIP-seq data, you can see that it has a binding site just at the 3' end and near the promoter of CDK6 and around the CDK6 locus, suggesting it may be binding CDK6 and activating the cell cycle. Another mechanism that we found in these hypermitotic meningiomas is that many of them had CDKN2AB deletions. We also found meningiomas that had CDKN2A hypermethylation. So if you compare the methylation levels of CDKN2A here or 2B here from Merlin or immune enriched versus hypermitotic, you can see that there's greater methylation, which is associated with potentially gene activation of the CDKN2AB, or I mean suppression of CDKN2AB, similar to their loss in the hypermitotic group. We also, when we looked at RNA sequencing and gene ontology analysis, the top 2 gene transcription factors were a transcription factor we've published previously, FOXM1, that's really important in activating the cell cycle and driving meningioma proliferation. What's amazing though is when we put all of these mechanisms together in hypermitotic meningiomas, these different mechanisms that we discover, if you remove duplicates, they describe 83% of the tumors in the discovery cohort. Suggesting that this is actually sort of a global process of these multiple different mechanisms that are converging on the cell cycle to activate that and drive the most aggressive meningiomas. That gave us the idea that maybe inhibiting the cell cycle could could decrease that. So we started with cell cultures. You can see here using CDK4/6 inhibitors. All these are different CDK4/6 inhibitors, abemaciclib, palbociclib, or ribociclib. And in 2 different meningioma cell lines, you can see a dose-dependent relationship at nanomolar doses for inhibition of colony-forming assays. We have an organoid model of meningioma, and when we treat these meningiomas with abemaciclib, you get decreased formation of little meningioids around the organoids. When we looked at mouse xenografts, if you implant them with CH157 xenografts, and as the tumors will grow, but if you start treatment after they are growing with abemaciclib, it slows that, and it slows the growth of the tumor, the volume, and then also lengthens survival. You can see the abemaciclib arm here compared to the control arm. And finally, we've had a handful of patients where we've used this off-label, and we'll talk a little bit about, it's also a group within the Alliance trial now, but we've used it off-label, and you can actually see this patient who started with a subtotal resection. You look at the tumor volume here on the y-axis, x-axis is time. They got proton treatment to the residual, it kept growing, went blind in the right eye. Then they got treated with bevacizumab, and then the tumor was progressing across to the other side, went blind there. We did radiosurgery, kept growing, started treatment with abemaciclib, tumor volume started shrinking, and the left eye vision was restored. So there may be some promise to using this in the future for these patients. And this patient had a 1P loss, 22Q loss, CDKN2A, very much a hypermitotic meningioma. So when we went back to my lady who I did the grade 1 resection on Ki-67 of 3%, when we did the methylation subgrouping of this, instead of just seeing methylation 0.99, we could see that she matched as an immune-enriched meningioma. What does that mean? Well, if you look at our curves compared to, this is at the 2-year survival point, compared to Merlin intact, she actually has maybe a 10 to 15% risk of recurrence within 2 years, particularly since, I may have left a few cells there by that venous lake that I couldn't resect. That's what I was showing here that we talked about. One of the things we developed, and it's in one of the supplemental figures of actually I think in one of the figures in the paper, is that how can you use this data in your practice? So if you do methylation profiling, you can add it into a nomogram with known meningioma risk factors. So we can start plugging in the things for our lady, see that she has a total risk score of 105. If you look here, we look at her 5-year progression-free survival. It's about, what is that, like 83, 84% chance it won't come back at 5 years, but it's not 0. So how does that affect my management? Well, I look at this and I say, hey, she has a few more genetic changes. Instead of waiting a full year, let's make sure she's not one of those people at the early part of the curve that has a recurrence, and maybe with this questionable residual. So I'm going to start with 6-month MRIs initially, and just follow her a little more closely. Let's switch gears and talk a little bit about atypical meningiomas and how this may influence management. These are 2 patients that I took care of this in the last year or so that I've been faculty. They're both 60-year-old people. We have the man on the right, on the screen left. He presented with a seizure, as did the 62-year-old woman on the right. Dr. Bant invited me to join her for this case. I did this case myself. So very similar tumors. We got Simpson grade 1 resections for both of them. Nice clean margins on the dura. Both had presented with seizures. When we look at the pathology, if you just look at the line, they both were WHO grade 2 meningiomas, not surprising given the size, the lack of sphericity, the apparent brain invasion looking appearance. This one, the man had clear cell changes, high cellularity, sheeting growth. The lady had, her Ki-67 was a little bit lower, but she had necrosis, also high cellularity, and this sheeting growth that you can see here. All features that made it grade 2. So the question then becomes, who should we radiate? And standard of care or kind of consensus care, I think most of us would agree just to observe WHO grade 1 meningiomas, maybe a role for adjuvant radiotherapy after subtotal resections of these if they're in a difficult place and you can't go back. Gross total resection grade 2 meningioma is very controversial. So like our patients, should you radiate or not? Subtotal resection, most people advocate at radiation as they do for grade 3s. I have a little notes that I've shared with a few friends where every time a new study comes out, people saying watch after gross total resection, people saying radiate after gross total resection. You know, there's clearly equipoise. If there was a recent meta-analysis by Chun, and he showed also maybe a favorable signal to radiation, but really not certain. And when we looked in our group of 565 patients here, we just said who got radiation and who didn't. And if you don't stratify them at all, methylation profiling, this is Merlin intact, immune enriched, and hypermitotic, there was no significant difference with adjuvant radiotherapy that came out as a sign with methylation profiling. So while methylation profiling was good at predicting recurrence, it's not really giving us a signal for radiation. We published a study a few years back where we looked at grade 2 gross totally resected meningiomas. And if the MIB1 was less than 7%, very few of those recurred. If it was greater than 7% and you did not give radiotherapy, 40% recurred. Whereas if you did give radiotherapy, and now we're talking smaller numbers, this is recursion partitioning analysis, no recurred. So if it's greater than 7%, a lot of times we would do that. But there truly is clinical equipoise. There's two trials, phase 3 going now, that randomize patients to receive 6 weeks of radiotherapy for grade 2 meningioma after gross total resection or not. And there's not many other cancers where we're still doing randomized trials for radiation. So we were interested in wondering, are there ways we could find a signal to predict response to radiation and outcome? So we started looking at our cohort, the discovery cohort from UCSF, narrowed it down where we had RNA sequencing on 173 of these tumors. This is an enriched group. You can see 40% grade 2 almost and 14% grade 3s for bad acting tumors. Then we validated that cohort in the Hong Kong cohort, which is a consecutive series, much more like what you would see in practice, 80% grade 1, 16% grade 2, 1% grade 3. And we developed a gene panel using genes that we know are important in meningioma, like CDKN2AB, and then also ones that came out as being associated with that in our RNA sequencing. And we developed a hybridization nanostring custom array with this and showed that there's a good correlation between the nanostring core, which is a very simple assay, costs about $50 to run, and RNA sequencing. And the first thing we found is that the gene panel stratifies patients based on recurrence, much like methylation did, area under the curve 0.7. And this also was predictive of overall survival in these patients in the low, intermediate, and high risk groups. If we compare the gene panel to the methylation grouping and the WHO grade, if you look at the accuracy of the WHO grade using area under the curve, the AUC, you can see it's about 0.67 for predicting local freedom from recurrence. DNA methylation profiling improves that to 0.74, and this gene expression risk score can actually improve the risk of recurrence prediction up to 0.8. We can incorporate this into as a gene expression risk score as a continuum into a nomogram as well. But what we were really excited about is there may be a signal in this gene panel that we identified. There is a signal to predict response to radiotherapy. So we started by just looking at our grade 2 meningiomas. And after gross total resection, those that had no radiotherapy or radiotherapy had with a low gene expression risk score had no benefit to radiotherapy. But those with a high gene expression risk score, there is a significant benefit hazard ratio of 0.5 for receiving radiotherapy. We then took all the meningiomas and propensity matched them by WHO grade, extent of resection, methylation group, MIB1 labeling index, loss of chromosome 1p, and really tried to compare apples to apples. And when we do that, not just grade 2s, we see a much stronger signal in the radiotherapy group, suggesting that the gene expression risk score may actually be a clear indicator of patients who can have a benefit for radiotherapy, or patients who may not need radiotherapy if they have a low gene expression risk score. RTOGO539 was a trial that stratified patients to receive radiation therapy based off known clinical risk factors. So those that were observed were grade 1, intermediate tumors were recurrent grade 1s, primary or gross totally resected grade 2s, or recurrent grade 3s. All these got radiotherapy. And when we put our patients in based on their clinical features into what they would have received in this, about 163 had a low gene expression risk score and a low clinical risk score. But 30% of the patients who had intermediate risk score or high risk score, 9%, actually had low gene expression risk score, suggesting that these were patients who would have gotten radiotherapy but didn't need it. And similarly, when we look at patients who had a higher or intermediate gene expression risk score with our nanostring panel, 32% of those low risk tumors clinically actually may have benefited from radiotherapy. So how does this influence my management of the case? Over on the right is my gentleman who had a Ki67 and these different chromosome losses. On the right is the lady, also grade 2, Ki67, 3 to 4%, and fewer chromosome changes. So if we look at where they would fall, the lady on the right, she has haploinsufficiency of chromosome 22 and loss of chromosome 8, but nothing else. So she's either Merlin intact or immune enriched, even though she's grade 2. And my gentleman on the left, he had a chromosome 1p loss, 1q gain. He had he had 6 gain. He had 9p loss, 14 and chromosome 22. So he matches much more like a hypermitotic tumor, high risk. If you look at what methylation group he would be in. So for him, even though I got a gross total resection, Simpson grade 1, I went forward with adjuvant radiotherapy because he's doing very well, neuro intact, back to work as a consultant here for a big international firm. But I think he'll benefit from radiation. We don't have gene panel data yet to show, would he or not, what was his gene expression risk score. But for the lady who was grade 2 on the right, I'm deciding to watch her. So we got an MRI at 3 months. We're going to look at, and then every 6 months after that, she is grade 2, but genetically, her tumor was much lower risk. So trying to bring these molecular advances into play in our patient management. I think the last thing I want to talk about is what can we do surgically to drive things? So that's really a wonderful options to have all that pathology available with Craig Korbinski here and be able to incorporate some of that, but we're surgeons. And so this is a case of somebody who had a grade 2 meningioma, 2 prior resections, fully fractionated radiotherapy, radiosurgery boost to the residual, and now he's got a growing residual here. We did an angiogram. My colleague, Matt Tate, got me involved in the case, and then Matt Potts did the angiogram. The sinus was occluded, which it hadn't been previously. So maybe we have a window where we could get a maximal resection for this. What I wanted to do was to get, I got a dotatate PET scan. Dotatate is a creatine analog that can be coupled to gallium-68 for PET imaging. It can also be coupled to lutetium-177 for targeted therapy. But for the PET imaging, it's just a radio tracer. PET imaging is very good. This is a great example from my friend, Dr. McDermott and mentor. You get it something like this. Is this tumor? Is this tumor? You get the dotatate and it lights right up. When we look at outcomes for radiation guided by dotatate, this is a European group showing that when they treated cavernous sinuses and they did their radiation planning with dotatate, none of the patients recurred. Whereas if they did it if they just had surgery or just standard fractionated radiotherapy, many of them recurred. So for this, this is kind of our one shot. The sinus is occluded. How much do we need to take out of this tumor to try to give him one last chance at surgery? So we got the dotatate PET. This is what that looks like. And you can see there's active areas of disease, but there's also areas that are unclear. What is background? What is tumor? This gives you a feel for it here. You can see clearly a hotspot residuals here and here, but this area out around the tumor, it's hard to tell what is signal or not. So we started looking at this. What do we do? So I took the tumor out. We planned to take everything out and then send image guided samples. So when we looked in the hotspot on the dotatate, definite active tumor, multiple mitotic figures that you can see here, WHO grade 2. When we look out at the margin, just pass. So I sent, like I talked about, I often am sending margins now, especially when I have any concern on the meningioma. Very clean, normal looking dura out here. Some of the epidural tumor that you don't know, is this old scar or is this tumor up in here underneath in the epidural space? That definitely recurrent active tumor, and it was positive on dotatate. We looked at one area here where there was some contrast enhancement, wondering about brain invasion. It wasn't too hot on dotatate. It kind of came out. This is non-eloquent brain behind sensory. So I just took all that out, sent it for pathology, just gliosis. So making me believe what the PET is showing. Then anteriorly, there were 2 big veins coming in, but I got right to the edge. I took a superior sagittal sinus margin, no tumor there. But this was the view intraoperatively. So you're looking, this is the left hemisphere of the brain. You have this big vein that's coming around into the superior sagittal sinus here. You have another one from the right plugging into the sinus there. So I took my tumor, as my resection as far as I could, closed off the sinus from a venous standpoint. This is kind of what the resection looked at the end, because I wanted to take out anything that might have been positive. These are the occipital poles here, the torcular. This is where we went in the brain, took out that margin there. It actually had invaded a little bit on the other side, so we took some out there. Removed all the bone, did a custom implant for him. You can see that there. So I would say this is kind of a Simpson's grade 0 resection. We had negative margins. It's recurrent WHO grade 2 meningioma, high Ki67. As you would expect, he had a 1Q gain, USF1. He was a hypermitotic on methylation profiling. So we've done a really nice job for him. I'm proud of the surgery. I think the dotatate helped me do a better surgery. But what do we do when he recurs? And I think this is some of where the challenges is. So the last couple minutes here, I'll just share a few of the trials that are ongoing so you can be aware of them. There's an immunotherapy trial looking at nivolumab for recurrent rare CNS tumors. Marta Pinas-Prado is the PI at NCI. We have it open here. The Alliance trial I'll talk about, tumor treating fields with bevacizumab, and Lutathera, which is being open at the Mayo. So immunotherapy, if you have a recurrent grade 2 or 3 meningioma, you can treat with nivolumab. You get imaging every few weeks, and they're looking for radiographic complete response or partial response and PFS at 6 months. That's a study run through the NCIs, and so many of us are sites for that, many of those cancer centers around the country. The second trial is the Alliance trial that's PI'd by Priscilla Brastianos. This was the first trial trying to get some semblance of a biomarker to guide treatment. They closed, there was an NF2 group that got a FAK inhibitor, smoothen mutations got vismodegib, which is an anti-sonic hedgehog drug. There's 2 arms still open now. One, if you have an NF2 mutation or any of the CDKN2As, you can get on abemaciclib, the abemaciclib arm. And then there's also some AKT-P10, PI3 kinase pathway inhibitor options. Another trial that's open here, that's a Northwestern trial, we're doing bevacizumab and tumor treating fields and looking at 6 months freedom from progression and radiographic responses. This came about because we had a patient that had this right temporal GBM, also an incidentally found meningioma. They got tumor treating fields, and what you can see at post-chemo RT, post-tumor treating fields, the meningioma actually responded. So that was kind of the impetus for us to think maybe there is actually a role of tumor treating fields here. There's a few patients that have had, like this one, that had a recurrent WHO grade 2 meningioma, had been resected twice, radiation with gamma knife and cyber knife and fully fractionated radiation. You know, she got bevacizumab, got a little better, but now 3 months off bev, just on tumor treating fields, we're not seeing any recurrence of this, this disease here that was growing back. So there may be a signal there. That trial's ongoing. The last trial I'll mention is from the Mayo Clinic, where they're using dotatate combined with lutetium-177, which is a radioactive element that can then go and ideally just target to the meningioma. And they're looking at recurrent, any grade recurrent tumors, and then following with serial dotatate PET MRIs. So wrapping up, I think as you've seen from some of the case examples, I don't think meningiomas are benign. Molecular discoveries are actually influencing patient care, and I think much of this will come to prime time soon. Both DNA methylation profiling, which we do in-house here, and I think has some really helpful benefits. It can design and inform treatments. The gene expression panel we have under review, we're revising. We got to ask for revisions at New England Journal. It's really exciting for us because this is the first time there's been a biomarker to predict response to radiotherapy based on the molecular features of the tumor. And as surgeons, maybe consider incorporating dotatate in some of these studies to see, can we do actually a total resection when it makes sense? And the future really is going to be finding these patients that have biomarkers that we can match to the right trial. I think cell cycle inhibitors may be promising, but if you've had any patients on the Alliance trial, they often come back. So I don't think it's a panacea. And with the biomarkers, they may help inform combinatorial therapies or other things that should help us treat meningiomas, because most of these don't have the blood-brain barrier problems that you have with glioblastoma, because they're outside of that. So really, we need to find a better treatment or trial based off the biology of the tumor. So my team at Northwestern, Craig Horbinski's neuropathology Priyakumthekar is one of our neuro-oncologists. Ryan Avery helps me with the dotatate. Dr. Lesniak's, my chair, has been hugely supportive. And much of the work, the science especially, has really been led by David Raleigh and a graduate student in the lab, Abrar Chowdhury, whose PhD thesis was, he was able to finish the project I started, and the whole lab contributed to that. Our collaborators, my funding. And I also just, this was Mike McDermott, who was a great mentor to me, kind of lit the fire in my mind for meningiomas. And being at UCSF, I was able to get going with the science side, which we're continuing in a collaborative manner, and with Craig Korbinski here at Northwestern now. So he was a driver and visionary, got funding, the Linda Wolf funding for this, that really gave us the millions of dollars of funding to actually get these projects going. So much of this is his legacy as well. So that's what I have. I hope it's interesting, and happy to take any questions or chat with Dr. Shaw and the others.
Great. Thanks so much, Steve. That was amazing. Really exciting to see, us pushing the field forward in meningiomas. Like you said, for many years, it was just kind of thought of this as a surgical or radiosurgery disease. And then these patients, when they come with these complex recurrences, nobody really knows what to do. And so it's about time that we kind of really figure this out as they're becoming more and more prevalent, and these patients are living older and longer, and we're having to make these tougher decisions with that. So I just want to get to the Q&A first. We'll get to those questions, and then we could go to the panel. The first one here is from Alim. He wanted to know, approaches to cavernous sinus meningiomas when they already have palsies. And I would actually just add a twist to that. And, are you finding yourself now, when these patients that have difficult to treat areas with small tumors, cavernous sinus meningiomas that are growing, do you find yourself now going more towards a biopsy to get this molecular profiling? Whereas before, in the past, we would just say, this is something we would probably just radiate first and then wait to see if it grows. But now it's kind of this question of, okay, do we really know if this is a grade 2? Is it a grade 3? Is it grade 1? Or is it one of these, do we need this molecular profile to understand a little bit about it and get this biopsy tissue more than you had in the past?
I absolutely think so. If you think about radiation, if it's a grade 1 meningioma in the cavernous sinus, you'd radiate to 50.4 gray. But if it's a grade 2 meningioma, you're going to push that to 54.4 gray. So you actually change what you do from a radiation standpoint. And similarly, I think if you got a biopsy and you do the gene expression risk panel and it's low, and then you do radiotherapy, maybe it's grade 2, so you say we'll go to 54. But if the gene expression is low, maybe you watch it. If you know it's growing, like in the scenario you mentioned, then you would treat with radiation, but you might push it to a higher dose based off the WHO grade, or an expression risk score that would say, hey, this person will really respond. Alternatively, if it comes back, maybe grade 1 with a low gene expression risk score, maybe this is somebody you just watch and don't radiate. Because we've all seen patients who had cavernous sinus meningiomas, and then you radiate them and you think it's good, and then all of a sudden the thing just goes crazy. And that might, I know Jennifer Moliterno at Yale has some ideas. I haven't seen it published yet, but has talked about that there may be some meningiomas we're actually harming by radiotherapy. So I'm fairly cautious about that, and I do think we're moving in that direction.
Degmara asks, at what point in the time are you doing NGS testing in atypical meningiomas? Are you doing it on the first surgery or the second surgery? I pretty much know what you're going to answer here, but go ahead.
So this is a real problem, actually, and something that many of the papers, Linda B had a very nice one, Driver et al. Recently, trying to understand what is the workup that we need to do, and then what is the workup that you can do. So at Northwestern, we've got Craig Korbinski, we can do methylation, we can do NGS, we actually run some gene fusion panels and other things. Like, we can do all this profiling, but that's not feasible everywhere. Not everybody has either the ability to do that or the interpretation. So I think histopathology still has a really important role. I think any grade 2 meningiomas should be profiled. And one of the things that we're trying to do with this paper we have under review at the New England Journal is really make this available to everyone. So we're working on developing a way, it's a relatively cheap assay, this gene expression panel, where we could have a service where you could send your samples and we could do that. In the absence of that, one of the things that Linda B. and I think is reasonable to propose is to look at 1p19q, because everybody can do that for glioma at most Western medical centers, not everywhere in the world, but that's if you have 1p loss, that's a pretty significant risk factor for that tumor. And so you can, I think a lot of it is tailoring what you can do to what you have. If you can go for a gene panel or something, if it's anything high grade, grade 2, 3, I would send to next generation sequencing if you can, but it's not really the mutations that are showing it. And I think that's one of the interesting things. It's not the DNA mutations that are really important, I don't think, in meningioma. It's much more so the methylation profile, our gene expression risk score, and the copy number changes, which get to the key mutations, the TERP mutation and CDKN2AB. Those should be done for everybody because they bump you to WHO grade 3 if there's any concerns now. But they're really rare. The TERP promoter, I think there was one in our series of 565 meningiomas. They're exceedingly rare.
And there has been some people asking, just kind of what you're alluding to, if they don't have these tests available, is there a way that they could send tissue or send samples to either you or other centers to get these tests done?
Yeah, so Craig Horbinski, we do methylation in-house profiling here. So you could just, like you would send it out, you could send it like you would to the Mayo Clinic or the NIH. I think NIH also does methylation. With our paper, there's an app. So if you get the actual methylation data, the IDAT files, you just upload them and it'll tell you which group they go into. There's some legal and risk challenges with this because trying to understand, like, is this a CLIA certified test? Part of what we're doing now is validating this in multiple additional cohorts so we can turn both the methylation profiling and gene expression into CLIA validated tests. Because if you're making clinical decision makings, like I'm talking about here, totally off label. Like this is just taking the best that I know at the research edge, but I can't, and I explain that to the patients. I tell them, hey, we really don't know. We haven't proved this. This isn't like a standard of care diagnostic. So I would do what you can to try to get answers to the molecular things, certainly CDKN2AB and TERP promoter that are in the new WHO grading. But beyond that, you really need to be in a place where you can interpret it and then also share with the patients that until this is validated, I'm trying to bring the latest to you, but this is really the research level. And I think that's also important in providing safe care.
Great. Ashish?
That was a fantastic talk. I really, really enjoyed it. It's really an inspiration for kind of young neurosurgeons like myself to try to aspire to something you've done here, which is really amazing. You're really changing the paradigm for meningiomas completely. So I applaud you for that. I really had two questions for you. One is I know you used the Hong Kong cohort and then you used a kind of American-based cohort, right? Initial study. Do you find any big differences between the ethnicities in those two cohorts in terms of their gene expression profiles, just because you have two different populations? I think you're muted.
That was one of the things that we were really excited about when we were able to develop the collaboration, because it is a different ethnic profile. San Francisco does have, where most of our samples from in California is enriched for Asians, but relative to other parts of the country. But I think it was the biology that came out of that, because we were able to validate our methylation in that group. Like the methylation held true, and the gene expression, we used them as a separate validation cohort. And that's also important because it was a consecutive cohort. Whereas like at UCSF, we were using our tumor bank samples, really enriching for long-term follow-up and high-grade tumors. But then is it applicable in a general setting? But I think that's also why we need to do this at multiple additional universities. And we're setting up collaborations to do that for this gene expression panel as well.
And then that's amazing. So then I guess the next question I had for you was kind of separate, was like, in patients who have gotten radiation therapy, and now these patients who come in kind of like the patients who have recurrent atypical meningiomas, you're going back like a third or fourth time operating. Are you seeing like changes in methylation patterns in those patients, specifically in the in patients who were CDKN2B who had the retained locus and then lost it like afterwards? Or do you see changes like kind of I know in GBMs, we kind of, these patients who had like CIMP high to CIMP low kind of phenotype, are you seeing those changes after radiation in those patients? Or?
We don't have enough paired samples. When I looked at recurrent meningiomas in clinical follow-up, like clinical outcomes, about 20% increased their WHO grade in McDermott's experience at UCSF when I was a resident. So of the recurrent tumors, if you looked at the original 2-grade, about 20% go up. But we don't have enough where we've done copy number sampling or methylation profiling on paired samples serially. And part of that is, when we try to apply this stuff to meningioma, it's not like glioblastoma. If you extend beyond 2 years, like you can get multiple surgeries, you can, like you're making your survival, like it happens fast. And to advance meningioma, and this is kind of that caveat about what do you say from this, like we aren't going to have answers to what does this matter for 10 years, for 15 years. And when I tell the patients, MRI has been around for 30 years, right? Or 35 years. Like, we don't have 40-year follow-up. So when I see that lady who's 39, who's going to live to 90, like, I don't know what's going to happen. And that's why I want to keep following her. And that's kind of the challenge, but excitement is, we can't do that type of a study very quickly. And it will take, like this is why it's a career level problem to discuss.
I can imagine. And then, sorry, I just have one more, just because you're like an expert in this. I just wanted to bug you about it. So local regional changes in terms of whenever you see these patients, if you sample, I know you mentioned sampling near like the sinus and then away from the sinus, are you seeing changes into the molecular biology of these tumors, local regionally? Like I know you have a nanostring platform, so I don't know if you've noticed changes.
Yeah, so that was the Nature Communications paper I did. We looked at different regional, like intratumor heterogeneity within them. One of the things that I'm like, some of the ways I want to take this scientifically is actually to try to understand invasion, because we don't know what's happening. And we didn't sample the dura. We did a couple, but we didn't get good data from it, so it's not in the paper. But I don't have that answer, and I think it's a really interesting question, and that's why I just started looking, because I'm like, it looks like the dura is clean, but I don't actually know if that's a clean margin. And that's kind of how we, Simpson used his eyes to look in a headlamp. He didn't even have a microscope, and that's kind of still how we function and say, the dura looks pretty normal, but we don't really know.
Awesome.
So that's what I'm trying to find out.
The question is, when you get the molecular profiling back, what are you going off of the treatment paradigm? Are you going off of the bulk sample that you have from that profile, or are you getting it off of these small margins where you've decided, surgically, this is what I need to leave, and then go off of that profile? And are you sending multiple profiles for each tumor? And does it matter which profile you end up treating? Yeah, it gets complicated.
Yeah. In the next 2 weeks, a paper will come out in Acta Neuropathology from our group where we did that on the heterogeneity samples. We did methylation, RNA sequencing, and it depends on the platform. Like the gene expression changes there's a lot more heterogeneity. But like when we looked at like what methylation group do they go into, kind of wherever you went in the tumor, even in the higher grade ones, they all were like hypermitotic or Merlin intact. So there is some copy number variance. We published that. We know that's true, but diagnosing this and figuring out the correct sampling is also challenging. And I think that's really an opportunity for people with really good radiomic collaborations to try to do the radiologic correlates with this, so we can say, hey, where should we be sending the samples? I mean, the same thing as like, do you sample for brain invasion or not?
Yeah. Awesome.
Who else do we have?
Tom?
Hey, Stephen, good to see you again.
Hey, how are you?
Great talk. Good, man. Good. Happy to see all your success over there, and it's amazing work and an amazing body of work that you've done on meningiomas over the years. I guess one question I had in terms of modeling of these processes, it's in terms of primary samples are obviously gold standard in terms of understanding what's going on. And forgive me if you addressed this early on, I was stuck in the OR, but in terms of in vitro systems and in vivo systems, so kind of model meningiomas and trying to capture methylation in a preserved manner over a long culture period. What's your strategy and thoughts on that in terms of the optimal system? I see you did a lot of different systems in some of your in vivo studies. What's your thought process on that and strategy for studying these?
Yeah, so in the models and what we've done, because we've developed a bunch of primary lines here with the Horbinsky lab, we do methylation profiling on those, and then we have a baseline, and we can see what group does it stratify with, does it classify as a meningioma and not something else. So I think that's actually really powerful in characterizing it. Like, do the cell cultures, does the model actually retain the epigenetic signature of the tumor that you're studying? And then, we'll follow those with passages, and every, so often, I think due diligence would be to keep profiling those, but we don't have like a protocol set up for that yet. But That's what we've started at, is just saying, like, what are these meningiomas we've cultured? We know the tumor they came from, but what methylation group are they?
Okay. Great.
Mitesh?
That was a phenomenal talk. That was really, really awesome. I think it was pretty interesting to see the use of the dotatate scans intraoperatively, sort of combining them with our navigation, like on that image that you had.
Yeah.
That was pretty cool. My question was just two quick questions. First one is use of intraoperative, like Raman spectroscopy. We've used some of that here at UM. How do you see this playing a role in, like, that decision you had to make regarding taking some more of that dura near the sinus and things like that? Do you think that'll play a role in decision making going forward, or have you utilized that at your institution?
I used Raman when I was at UCSF. It's super cool, and you guys are definitely one of the leaders in it. So congratulations to Mike and everyone there. And I don't have it here. I could definitely foresee, if you had a margin, like I just send frozen sections and I have to wait for them, that could expedite the case. I think what we run into with meningiomas is we're limited by the anatomy. Like in some of those intraoperative pictures I showed you, like I couldn't have taken more sinus. Right. Like I pulled the tumor out, I got back bleeding, I sutured it shut, the veins were coming in on either side. Like, it's the venous anatomy that limited me. So I think sending a permanent from that margin, knowing, like, is there a risk here? That helps set expectations, So for this guy with clean margins, I'm actually kind of a little excited. Like maybe we did something with surgery, but I'm not going to bet against biology. But, I think in areas where you're not limited by that, having a quick margin would be awesome. And if you had, the way you guys are pushing with AI and the Raman interpretation, being able to just 2 minutes, you're like, oh, clean dura. All right, that's far enough. Or hey, we need to extend our craniotomy. There's still meningioma in this dural tail. I think I could see that definitely being useful.
And the only other question I had was a little bit unrelated, but we had done the Gamma Knife course with McDermott here at Baptist, and there was mention of preoperative radiation for tumors, before surgery, which was a bit novel to me. In my training, I had not come across that. But what are your thoughts on that?
I love it for Mets. Yeah, I've been trying to push us to get a program going here for preoperative SRS for Mets, because then, the patient is done when you take out the tumor and the margins are really obvious and there's not floppy brain hanging around. I did that when I was in fellowship at Ohio State. That was the first time I really was exposed to it. I haven't gotten it off the ground here, but I've asked, there have been 2 cases we tried to do it, didn't work out. But I think for Mets, the data is really positive that it decreases the risk of leptomeningeal disease. In meningioma, I don't really think so, based on the nature of the disease. But it's definitely something to consider, but I think of it more in the role of Mets. I don't know if Mike has any thoughts on that as well.
Yeah, no, I agree. I mean, I think, and Mets is definitely the most likely case going forward. I mean, I think meningioma is like your talk, it's really going to depend upon the molecular profiling, and it's going to take time to get that. I mean, right now we don't have that available, but it does ask the question though, preoperatively on imaging. You guys have looked at this database that you've generated now probably in 19 different ways and with different kind of variables to come up with those outcomes. But did you ever look at anything preoperatively besides the age? I guess it was age and sex. What else preoperatively did you look at? Was there anything imaging that kind of stood out to you as concerns?
Yeah, we published, I think it was in 2019 or something like that, in Neuro-Oncology. It's Morin et al., Olivier Morin, who was a physicist with us. And we looked at that, and they did some radiomic analysis. And the main thing that came out is actually significantly helpful at predicting is sphericity. And there was a paper, I think just in JNS this week or last week, talking about a sphericity index and kind of how to calculate that. But we all know the meningiomas, when you get in there and there's little bubbles on the sides and they're popping out, the little growths, or they have multiple nodules, those are more likely to be grade 2s. So certainly I think the round balls are more likely to be grade 1s. And it helps me, like that lady, who ended up being grade 1, when I looked at it, I saw the bone invasion, it looked to me, and it does the same things that you kind of say, this may be one that's reasonable to take to surgery up front as opposed to sitting on in somebody this young. And then we showed, Jake Young and I showed in a focus paper a couple years ago that size is correlated with Hu grade. So these giant tumors, or giant ones, and the ones that have a low sphericity, lots of nodules and stuff, those are definitely higher risk. But we don't, I think there's space, and if with all those radiomic things, finding how, like, getting it to a place where we can actually use it in the clinic is what we need. It's cool to see a model or something like that, but how do I run my scan through it? And that's, to me, been the biggest frustration, trying to make this stuff practical for us as surgeons who have to come up with a plan for the patient.
Great. Okay, well, I mean, this was a great talk. Thank you again so much, Steve, and we encourage you to keep on the pathway here, because there's no doubt that this is going to lead to how we all change our practice for meningiomas. So congratulations. My best to you and everybody back there at Chicago, and stay safe.
Thank you so much. Thank you for the invitation. Thank you all for your time watching, and to the panelists.
All right, take care.